Okay, can you see my screen now?
Absolutely.
طيب تفضل.
The people are joining بس ننتظر كده
ايوه ايوه
بإذنك
ايوه
5 دقائق إن شاء الله.
طيب اذا انا Assalamu alaikum. I think we can start, Hisham.
وعليكم السلام يا بروف.
والسلام ورحمة الله.
It's okay.
طيب بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, good afternoon and good morning, good evening from where you're joining ShareCon 2023. Welcome to day 2 pre-conference workshop session. Our host today will be our esteemed Professor Abdul Munaim Sahl Al-Mardi, talking about constructing OSCE station, an important topic. Indeed, we are honored and very gratitude to have him with us in this conference. The microphone is yours, Professor Abdul Munaim, and we hope we enjoy an insightful session with very engagement from the participant, inshallah. Welcome, Professor Sahad.
Thank you very much, Hisham. Thank you, ladies and gentlemen, for joining this workshop. In fact, it's not about just quality OSCE station, it's about quality OSCE. And part of it is actually the station. So we are going to go through the steps of actually preparing and organizing an OSCE. And the major part is about the OSCE station. And so in this workshop, it's going to be about the OSCE quality, how to guarantee quality preparation and quality conduction of an objective structural clinical examination. I guess the participants joining this session are already aware of what the OSCE is and the rationale behind using the OSCE and all of that. So I don't think we need to go into these details. But I'm going to start the talk, which is about quality, but not this quality, but this is good also. I'm going to start with what quality management is, because it's a very important concept. We need to introduce it very quickly. And then part of it is quality in higher education. How do we assure quality in higher education as a foundational information about quality? and then we will go into how should it be done with regards to the OSCE. So we will start with what is quality management. And of course, this is a term which is being used quite often for the past decades because they consider this age the age of quality and accreditation. This decade, these 10 years, the issue of quality is now gaining, it started gaining popularity ever since. So it's very important. But what these terms mean. The definition of quality in general, it applies to an object. And this object can be a product, a service, or a process. So if you say the quality of a product, then you are talking about a product, whatever that product is. Maybe a graduate is a product, or the quality of a service you are providing, or the quality of a process. So quality, it applies to this, is defined as the degree to which a set of inherent characteristics, the inherent characteristics of the product, the service, or the process, all of them, they satisfy a set of requirements. This is the definition of quality. So it is a degree to which a set of inherent characteristics of the object satisfied a set of requirements. Now, therefore, the quality of an object, for example, is determined by comparing a predetermined set of characteristics against a set of requirements. And of course, we need to differentiate between what characteristic is and what a requirement is. So we need to go a little bit into these definitions. In business, generally speaking, in business, they define quality as a measure of excellence or state of being free from defect, deficiencies, and significant variation. So in the business world, they define quality as a measure of excellence or a state of being free from defects, deficiencies, and significant variation. So, for example, if I'm going to quote a process in academia, in education, if I am conducting an exam, I would like this exam to be free from defects, free from deficiencies, and free from significant variations. So we will see in a little while how are we going to apply this to academia. ISO defined it differently, and ISO, the International Organization for Standardization, defined it as the totality of features and characteristics of a product or service that bears its ability to satisfy stated or implied needs. So they are all defining the same thing but using different wording. And so also it is defined as the extent of compliance. So if I set standards, I will come and measure to what extent you are compliant with these standards or requirements and specifications. And as you can also see, the words repeated are standards, requirements, and specifications. And of course, you all working in academia, and you are often visited by accreditation agencies, and these are the things that they will look at. Are you compliant with the standards? Are you compliant with the requirements? Are you doing the things according to the specifications set in their documents? And of course, standards is an important term, and standards are actually set by governing and regulatory bodies. Yani when we say standards, معناها it's a governing body setting particular standards to measure your products or services or processes according to these standards. Now, while requirements, these are usually expected by customers. And for example, we are talking about academia, we are talking about educational institutions. Our customers are the community, the parents, the students, and all of those, including also the teachers in the institution. They have got requirements, and they set these expectations. And actually, the standards set by governing bodies are a reflection of the expectations of the customers. Now, specifications, on the other hand, set by governing and regulatory bodies, and they are actually speaking about the features of the product, specifications. And these same terms are used in industry and are used in business. So these are three different, very important terms in relation to quality. Okay, these there are. This is a summary of the different definitions I just quoted, and therefore quality could have any of the following meanings according to these definitions. It can be the degree of excellence, as said by business, conformance with requirements, fitness for use, fitness for purpose, freedom from defects, imperfections, or contamination, delighting customers. So any of these terms derived from the definitions of the various bodies and institutions can define sorry for that, can define quality. Now, these definitions can be also summarized in this final statement. First of all, the statement starts with extent, because you cannot have total compliance. You will actually be looking at the extent of compliance or degree. The extent or degree of compliance of a product or service with needs, requirements, specifications, and standards. So this is the summary statement regarding quality. I would like to check now interaction. I want to see whether people can unmute themselves and interact with me or not. Which of these phones do you think is of higher quality? Can people unmute and answer, Hisham?
Yes, they can. They need to raise their hands and then they can unmute.
Okay.
There are also some posts in the chat.
Okay. But I would like to hear some of them, because going to the chat and coming back to the presentation not that easy.
Dr. Samah, please, you can, you can open your microphone and participate.
عليكم ورحمة الله يا بروف. The fairest one or the oldest one اللي هو نوكيا 3010
Okay.
has the highest quality.
Why do you think it has not the highest quality?
الثاني فيه يعني a lot of programs and a lot of apps ما نفس الحاجات ال available في 3010 لكن يعني نوكيا كان you can throw it and you can beat a wall with it and didn't break up. لكن النوع الثاني ما بيستحمل، فالكواليتي في التصنيع في الأول في نوكيا it's better or it's the best.
Well, how did we define quality? Quality is the extent of compliance with the standards, specifications, and requirements. So, are you saying that the only requirement is being not breakable, and this is why Nokia is better? No. There are certain requirements, standards, and specifications. And by the way, both of them are of high quality, because the specifications set for Nokia by the clients, but according to their own needs. They specify certain needs, and these are converted into requirements and converted into specification. And when they manufacture Nokia 3310, they produced it at the highest level of these specifications. At the same time, there were other versions, other mobile phones for the same type of need and specifications, but not at the extent of quality is not that of Nokia. The point is, it depends on the standards, the requirements, and the specification, and not, you do not compare two different things, because each of them has got its own requirements, its own needs. I mean, satisfying particular needs, and there are specifications made, and there are standards for the manufacturer made, and when they manufacture them to the highest standards of quality. And this is the point I was trying to make. It doesn't, you cannot just compare things. Each of them can be compared to the standards, to the specifications, and to the requirements. Okay, this is quality in general. Now we need to be able to manage this issue, manage quality. So what is quality management? Quality management is actually the act of overseeing all activities and tasks that must be accomplished to maintain a desired level of excellence, to maintain a desired quality. Level of excellence, we call it quality. So what are these overall the activities? What are the activities and tasks? And then we are overseeing them, and we are determining how should they be done and all of that. This is called quality management. We don't want to go into the details of what is total quality management. Generally speaking, there is something called quality management, and this includes the determination of a policy, a quality policy, creating and implementing quality planning and assurance, and then there is something called quality control, and then quality improvement. People who heard about quality, or they were trained on quality, they know these 4 levels. The quality planning and assurance, the quality control, and the quality improvement based on the quality policy. So this is a summary of this diagram. The totality is quality management, which is coordinated customer-focused management activity, including continuous improvement. And then we have quality assurance, the confidence that quality requirements are being met, and then quality control, which is QC, meeting the criteria by checking the product or the service at the end. And the 4th level is the continuous quality improvement, and this was described by Kaizen from Japan, and it tells you about how you can continuously improve using this quality cycle. Okay, this is the general definition of quality and quality management. So how this is related to academia, higher education. Now, quality management in higher education, in fact, we need to start with quality assurance. I mean, we need to establish a quality system, and part of that is that you make sure you have processes in place that maintain quality. So quality education needs to be ensured through the development of a quality management system. And if you are working in a university, you will definitely have a guide or a manual or a book called the QMS. And the QMS is the quality management system in an educational institution. And according to this quality management system, you have the assurance and the control and the policy and the continuous improvement. So you need to plan for that. So it includes the policies, the procedures, the guidelines, the guides, the templates, the forms, and of course, in your institution, you have all of these things. You have the policies and procedures, you have the guidelines, you have booklets, we call them guides, and you have templates to be used, and you have forms to be filled. So all of this material is part of what is known as the quality management system of educational institution. So for OSCE, it's a part of this management, and it is part of the management of assessment. So you need, as an educator in an educational institution, you need to ensure that in the quality management system, there is a part which manages the quality of assessment. And as part of the quality of assessment, you have the quality of the objective structure clinical examination. So this is regarding the quality management in higher education. It is done through a quality management system. Now, how do we do it? How should it be done, in fact? Now, how do we do it? I mean, the procedure of doing this quality assurance or quality management. So first of all, this is done, you must make sure that during the development of a quality management system, that processes pertaining to assessment are identified. If you are part of a policy review or quality system review educator, you need to look very carefully at the system and make sure that there are processes pertaining to assessment and that are identified and are included. It should be ensured that policies governing these processes are also included in the system. There are policies related to assessment and detail. And then, based on those policies and procedures, guidelines for these processes are developed and should be circulated. And usually people circulate them in the form of a guide. The guide can be issued by an institution. For example, this guide was issued by the Saudi Commission for Health Specialties, and it's called the Objective Structured Clinical Examination. It's an OSCE manual. In that manual, they determine various things and they refer to the policies in the institution. Now, once in the system you have these policies, you have the processes, the guidelines for them, you produce guides, you need to train on the various aspects of the assessment cycle. So in any institution, to ensure quality, you need to train your faculty on the various aspects of the assessment cycle. And when I say the assessment cycle, I am talking at the quality cycle of assessment, which includes planning as the quality cycle in general, planning and preparation, and then the actual conduction of assessment, examinations and assignments and all these things. And then there is actually converting these assessment activities into values and grades, and then you make decisions and you close the loop. This is an action. So this is an assessment cycle. You need to ensure that all the aspects of the assessment cycle are covered in the policies, and also the faculty receive training on these parts of the aspects of the quality cycle of assessment. Now, also, monitoring and evaluation of this implementation should be done to ensure that this is actually the quality control part of it. Okay, as far as the OSCE is concerned, the OSCE follows the steps of the assessment cycle. If you don't do it in the way the assessment cycle goes, then you might have a problem here or there. So what are the steps? You need to plan, you need to deliver, you need to do post-measurement actions, and you need to make decisions based on the post-measurement actions. So these are 4 steps of the cycle, and they should be followed when you are dealing with the OSCE or the objective structured clinical examination. And all these should be done according to policies and procedures. That I already mentioned. They should be there in the quality management system. Now, what do we mean when we say planning activities? Because now we are going to start dealing with the OSCE as an OSCE. So you need to start with blueprinting, and this blueprinting later on we will talk about how do and who does and when do the 6 W's of blueprinting. We will address that later. But generally speaking, the blueprints are usually created or produced during the planning phase of the rotation or the course. When you are planning the course, when you are producing the course specification document, you attach a course blueprint. And then from the course blueprint, you can start designing examination blueprints. You need to make an examination blueprint for the written exam. You need to make a blueprint for the OSCE and so on. So these blueprinting issues are usually addressed in the pre-planning and preparation stage. Also, during the planning, you need to construct or design or author items or stations when we are dealing with OSCE, so we call them OSCE stations, but they are items like the MCQ items and all other items. So you also need to plan for and construct or design stations. Then you need to construct exams, and after you construct them, you actually check them for quality, and we call this moderation. So you prepare for moderation, you prepare and you check them before actually the exam is delivered. And then you need to prepare for the logistics of the conduction of the exam, and you will see later on that preparing for the logistics of the OSCE are most important and essential. If you don't do them properly, then you will have a problematic OSCE. And then you need to do a process of standard setting, because it is more important for the OSCE than it is for other types of exams, because there are observations and reservations surrounding the objective structured clinical examination. So you need to know how standard setting is done, and you need to do it carefully and appropriately. So these are the planning activities. You need to do them before you conduct an OSCE. And we are going to go through the process of item construction in detail, but we will also touch upon the construction of exams. Okay, now during the delivery of the OSCE, to ensure quality, you also need to take care of the following. During the delivery and before the examination starts, you need to orient the candidates and the examiners. You need to conduct an orientation session for both of them. And then you need to prepare a plan for the management of the candidates' flow, and you need to implement that plan. And there are many issues related to that. Maybe in the Q&A section of this workshop, you can ask and we can discuss the management of candidate flow issues. Just an example. Some institutions have three, for example, runs of the OSCE. So there are three groups. Group A will do it, for example, in the first 2 hours, and then in the second 2 hours, Group B will come and be examined, and then in the following 2 hours, the third group. How do you manage the flow of these candidates? Do you bring all of them and imprison them in a big hall? And how do you manage the candidates' flow? This is dependent on what people think about this issue. Okay, the cycles and the streams. When I say cycles, we might have 2 or 3 streams running in parallel, and then we have repetition. Repetitions are the cycles, and the streams are the actual runs running at the same time. How do you manage them? This is very important, because if this is not managed properly, you will also have a problematic OSCE. Also, things that should not be overlooked is the caring for the patients. If you are using real patients or even real and standardized patients, there are real patients and they need to be cared for. You need to prepare things for them. You need to prepare a restroom for them and all of that. So during the delivery, these issues need to be managed very carefully as part of the quality management of the OSCE, and it's part of the assurance that this OSCE will not be a problematic one. Okay, once you are done, you last conducted the exam and you took care of the issues I mentioned above, you need to do some post-measurement actions. As the OSCE is finished, we collected all the papers. What do we do? First of all, you analyze the items to make sure that there are no problematic items. And of course, you are all educators and you know What do we mean by item analysis? Is a station too easy? Is a station too difficult? This is called the difficulty index. Does it discriminate between different examinees? So you need to analyze items, and if there are problematic items, you need to examine the items themselves. And if the item is problematic, is proven to be problematic, then it has to be dealt with. Also, you need to compile the marks. And when the marks are compiled, there is something called verification or validation of the compilation. If you need to take a sample and check, and you need to actually give the compiled marks to somebody else to check before they are publicized. And then before you also publish the results, you need to analyze them to see whether the performance is as expected, is normal, is as expected. So you need to do these things post-measurement after you conduct the exam. Then what about decision making? There are decisions you apply the regulations to decide on who passes. And this is very important. We are not going to discuss this today, but this is a very important issue if you want to guarantee the quality of the whole process. So you need to decide beforehand who will pass. Who will pass? The OSCE. So I have an exam. It has got 16 stations. Who is going to pass? When I announce that this student has passed this examination, does it depend on a mark? If he scores 60% or 70% or 80%? Will it depend on a number of stations? Is it depend on passing something called the must pass station? Is there something called red flag stations? So all of these you need to decide who passes. And this should be determined beforehand. But you come and apply it, you apply these regulations or these policies to decide who passes. And then who passes the rotation. This OSCE is going to be compiled with other parts of the exams of the rotation or the course, and then you need to apply regulations to decide on who passes the rotation. Now you have the chance to ask questions about this general outline of quality of the OSCE before we go into the details of preparing stations. Okay, now you have the chance to ask questions. Okay, since there is silence, it means there are no questions. Let me just start my next presentation. There it is.
Professor Sahel,
Yes.
I would like just to pass one of the questions received in the chat from Dr. Sulafa Muhammad. She said, I'm quoting, thank you, Professor. What do you mean by rotation?
A clinical rotation. We call the clinical clerkship the clinical rotation, or the clinical clerkship, the course. The clinical courses are called clinical rotations or clinical clerkships because they are usually done in the form of rotations. Students will go to medicine first, and then one group will go to medicine, one group will go to surgery, one group will go to obstetrics and gynecology, and then they rotate. This is why they are called clinical rotations.
Thank you very much. There is no more questions in the chat or the Q&A.
Okay, now we start discussing how stations are designed. In this talk, I'm going to give a general introduction, and then people design stations and bank them. So there is a process for designing stations for banking. And then there is a different process to the stations for the exam. What do you do if you are designing a station for the exam, or you are pulling a station from the bank and preparing it for the exam? So these are the three parts of the talk. I will start with an introduction to this issue. Now, as I mentioned in the quality part, you need to plan first before you prepare. You need to decide on what are the stations. You need to decide who is going to design this station. And is it going to be a group for each station, or is it going to be a number of stations given to an individual, and when the individual brings them, then we have a look at them. So all of those planning issues are addressed first. And there are certain recommendations. The first recommendation, yes, stations can be designed by individuals. We call them station authors or stations designers. But it is better to be designed by a group. Instead of designing it by individuals and then referring it to other people to have a look at it, if they do it from the beginning in the form of groups, then you will be efficient. So this is the first recommendation. The second recommendation, they are should be designed upfront or beforehand or before the exam, long time before the exam. And the best thing is to design them. You get them checked for objectivity. You get them calibrated. You get them tested, and all of that before you actually bank them. So these are designed for banking. And of course, to design a station, there are various elements you need to take care of. These elements include a long list of elements, but you need to take them one at a time. And to make this design effective, you need to think of particular purpose and level in mind. So if you are given the task of designing a station for, to test the ability of the candidate to examine the chest for a cardiovascular problem, and they told you that we need a problem in which the patient has got MI, myocardial infarction. And this is going to be used for example, third year medical students where they are doing the cardiovascular module. And we want to just test their ability to apply the technique of examination of the heart. So you have a particular purpose and a particular level in mind when you design, but you design it in a way that it can be modified to suit a different purpose and a different level. So this is generally speaking. Now, when you plan for the OSCE station, what are the elements? I just mentioned that there are different elements that you can use. So what are these elements? Now, when you design for banking, the elements are the following. First of all, you need to write what is known as the station's profile. And this station profile is very important for actually banking of the stations and for, in fact, pulling them from the bank, because they are described in this profile. And if I want one station which addresses this issue, addresses this level, it has got this and that, this is written in a station's profile. We will detail the station profile in a minute. So this is the first element. So you take a paper and you write, or the group writes, the station profile, and in that station profile we will describe what goes into that profile. Then you prepare what is known as a context stimulant. Context stimulant can be a preface, just a preface, or it can be a patient's scenario, a short patient's scenario. Then you write instructions. So the first one you wrote the profile, the second one you wrote the context stimulant, then you write instructions. And instructions are written for the candidate, and this is the actual task. You write instructions to the examiner, and if you have a patient, whether this patient is real or simulated, you write instructions for the patient. So there are instructions for 3 categories of stakeholders in the OSCE. Then you prepare a marking sheet, and then you prepare a list of requirements. So these are the important elements. We will take them one by one. The first one is the station profile. And this is, as I mentioned earlier, is used for the classification of the station and for the banking of that station. Because it is now classified, it is coded, and it is given a code, and then it is put in the bank in the right place for it. So this station profile is very important for that. And it is also, as I mentioned earlier, it's also used to pull the station of the bank to fulfill a particular purpose in an exam. Now, you usually start with a title, specifying the clinical problem if it's a clinical problem. If it's a clinical problem, then the profile will say a young patient with myocardial infarction. So it's a title if it's a clinical, specifying the clinical condition. And this can be followed by the objective or the purpose of the station, the task. It's a case of myocardial infarction, and for example, it can be used for counseling. So even the objective is counseling. It's an MI case, but it's for counseling. Or it's an MI case, but it is for history taking. Or it is for the breaking of bad news, or whatever. So either then you can specify the objective or the purpose or the task of the station in the profile. Now, the objective is what the candidate is expected to do. This can be written then as the task. It must be specific when you write it. Now we are going to spell it. Instead of saying history taking, now you write exactly what do you want the candidate to do. It must be very specific. Please interview this patient or the patient in the station, trying to determine whatever, blah, blah, blah. It must be specific and objective, written in a way that anybody who reads it knows what exactly needs to be done. And it must be something measurable. You don't write something which is too difficult to measure. So
Professor
this is,
Sahal,
yes?
sorry for interruption, but your screen, you're not sharing your screen right now.
من جبال ولا الآن اختفت؟
A few minutes.
لا أنا ما عملت أي حاجة يعني let me check. أنا ما غيرت حاجة. I have not stopped sharing.
Yeah, if you can try to share it again.
Yeah, sure. Maybe when I stopped I didn't. الكلام اللي فات ده كله الناس ما شافوه ولا شنو؟ window.
ما شفناه يا بروف. 2 minutes ago كده يعني.
2 minutes. 2 minutes talk.
2 minutes fast talk like you can. طيب الآن can you see it now?
Affirmative.
Okay. We started with an introduction. Okay, and let us go straight to elements. Now you can see the list of elements. Huh? This is what you need to prepare because this is most important. You need to prepare a status profile, a context stimulant, which is the same as the objective, instructions to 3, the candidate, the examiner, the patient, and the patient. And then you need to prepare a marking sheet, and then you need to prepare a list of requirements. So if we start with, by the way, it's not in the presentation. Is it in the presentation mode? or no? Okay, yes. Now I go there. Okay, this is the list. This is the list of elements, and I started describing the first element, which is the station profile. And I said this is used for the classification and banking of the station. Usually starts with the title, and the title is usually a clinical condition, if it's relevant, of course, because you might have just an X-ray, so you don't need the clinical condition to write for that. So it's followed by the objective or the purpose and the task, and this is what the candidate is expected to actually do in the station. And this must be specific, objective, and measurable. For example, abdominal palpation, if you say palpate the abdomen, this is a more objective and specific than examine the abdomen. Because examine the abdomen means everything. So if you want to be specific and objective, you will say this as a purpose. By the way, let us specify the difference between objective or purpose and context stimulus or the instruction to the candidate. Here we say the objective is to check the ability of the candidates to palpate the abdomen. Later on, we will say what is the task. The task, please palpate the abdomen, blah, 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 blah. So it's different. The objective is a general thing, while the instruction to the candidate is a direct instruction. We will see that when we come to that. So here in the profile, you just state the objective or the purpose of the task in general. Okay, you also in the station profile, you specify the item to be used in the station. Is it going to be a patient? Or if it's a patient, is it a real patient? Or if it's a real patient, is it a standardized patient? Or somebody brought just now from the outpatient clinic? Or is it going to be a simulated patient? Is it going to be a mannequin? Or is it going to be a chest X-ray, an ECG? What is it? What is the item that is going to be used during the performance of the task? This is written in the station's profile. What is your proposed item? For example, you can say it's preferably a real patient, but if not, a simulated patient will do. But examination of the thyroid can be done even if it's not enlarged, so it can be done in a simulated patient. But if you want to detect a murmur, this cannot be in a simulated patient. You need a real patient. So you need to specify the item to be used during the performance. You also need to specify the most suitable examiner. Do you need a consultant? Do you need just a trainee? Do you want, for example, what? What do you want as an examiner? Maybe a nurse, if it's a measurement of the blood pressure or something simple, or not. They know many things that they are capable of examining. So you can specify the most suitable examiner. Also here you can say this should be done by this, but if not available, then another level, a registrar can do it. So the most suitable examiner, and then the most suitable duration for that station. And you need to be careful about that, because we have something called, we will talk about it later, we call it the station calibration. When we calibrate the station, it is not only the symptom and signs, we're going to check them in the patient, but we are also going to check whether the time specified is too long or too short or just enough. So you need to specify the most suitable duration in the station's profile. So these are the issues you write in the station profile. So once you're done with the station profile, which is usually written in one sheet of paper, a separate sheet of paper, you use another sheet of paper to write the context stimulant. The two words are chosen very carefully because you need to specify the context. you need to specify whether this is in an outpatient clinic or in a ward or on the street, or you'll find lying down in the classroom. The context is important, and it's a stimulant for the candidate for the task. So it is called the context stimulant. Maybe it is not the task itself, but you write a patient scenario, for example, and this patient scenario is used as a context stimulant before you actually write the instruction. And therefore, it could be a preface to the task. For example, the mannequin in the station represents a patient who was found unconscious on the floor of his room. This is a preface. This is a preface. Now, what is the task? Can you perform CPR or whatever? The task is CPR, but the preface is this introductory state. It's called a context stimulant. Then you need a brief description of the item used to perform the task. As I mentioned earlier, this patient was hit by a car and he has got bruise in his right arm, etc. So it's a brief description of the item used. Maybe the item in the or the X-ray in the viewing box is that of a patient who had a car accident to his right side. So it's a preface and a description of the item used to perform the task. Usually, it's a short scenario if the item is a patient, and whether this patient is real or simulated, you need to write a case scenario describing the patient. For example, this is the example I just mentioned. The X-ray in the viewing box is that of a child who was blah 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 blah. So this is a preface describing the item to be used for the task. Then, I mean, the purpose of this context stimulant is correlation between the task being performed and the clinical context. So you need to correlate. And you need to prepare the mindset of the candidate before you ask him to do this. You cannot just jump in and ask the candidate to examine the chest of this lady. You need to prepare the mindset, and you need to correlate with the clinical condition. So you need to prepare the mindset. And by the way, some studies were done in which OSCE stations used scenarios to prepare the mindset or preface, and OSCE stations in which they straight away went into instructions. And they checked and they prepared a huge difference between using the context stimulant and not using them. They prepared the mindset, and the performance is expected to be better by the candidates. This is just an example. You are a junior doctor working in accident and emergency. This patient presents with a headache. The name of the patient is Malcolm Smith, and the date of birth is the 1st of October 1952. His age is 71. This is the context stimulant. Now, this is not supposed to be in the same page, but I brought it to show you what sort of task can be used with this context stimulant. For example, take a history from the patient, review the initial investigations, state your preferred diagnosis and reasoning to the examiner, and give your initial management plan to the examiner. You are not required to examine the patient. This is not part of the context stimulant. I just brought it, although it is instructions to the candidate to show you how you are going to use the context stimulant. So the context stimulant is just to simulate, to correlate, but some people just go straight and say, take a history from the patient and review the initial, etc., without giving them this context stimulant, and you leave them to ask for them. As a result of the study indicated that giving a little bit of the scenario helps the student to prepare their mindset, and their performance improves. These are other examples of context stimulants. For example, this candidate information is up there, and then you say, Mr. Mahradon is a 65-year-old woman, Mrs., who presents to her GP with painful and swollen hands. Please examine her hands and then speak to the examiner about the most likely diagnosis and investigations you would perform to confirm this. This is the task. It's not part of the context stimulant, but I always bring it to show you why do we put the context stimulant, because if you go straight to the task, they might not be helped by this piece of information. Another example is you are a junior doctor working in an accident and emergency. His Bryce is a 59-year-old Gilda and has a painful left knee in the absence of any recent trauma or injury. He thinks it might be swollen. Normally, he is well with no past medical history and takes no regular medications. This is the patient scenario or the context stimulant. A sort of question would be: examine Mr. Price's knee and present your findings to the examiner. Later on, we are going to discuss this format of the task or the instructions to the candidate. Okay, this is the context stimulus and with examples. Now, when you prepare instructions, you prepare, as I mentioned earlier, 3 types of instructions. One list or one instruction for the candidate, the task to be performed, one for the examiner and one for the patient. These instructions are very important, should be very carefully prepared. So when you prepare instructions to the candidate, you need to be very specific. You need to specify the task to be performed and as objective as possible. I gave the example of examine the abdomen and palpate the abdomen. Palpate the abdomen is more objective than examine the abdomen. The most subjective or totally unobjective, examine this patient. Examine this patient as well. Which part of the patient? Where do I start from? So you need to be as specific and as objective as possible. Now, objectivity goes beyond being specific. Being objective, specify exactly what do you want the candidate to do. Is it just examine? Do I need to say something while I am examining? Do I need to say something after I finish examining? And so on. So objectivity doesn't only cover what needs to be done as far as the patient is concerned or the item, but how and when you finish, what do you do? All of that is part of the objective. So, for example, do you need the need for a running commentary? Do I say, now I am sitting on the right of the patient, I am warming my hand because of this and that, I am trying to look at the skin to see whatever is there and blah, blah, blah. This is called a running commentary. You need to explicitly mention, is it needed or not? Because this and other things will determine what goes in the checklist. Also, the need for interaction with the examiners should also be explicit. Do you tell the candidate, respond to the questions by the examiner? Do you want to say, tell the examiner whatever you want from the examinee, from the candidate, should be explicitly mentioned in the instructions. And this will determine what goes into the scoring or the marking form. So these are very important issues related to the instructions. This is just an example. Examine the swelling to determine its characteristics and possible diagnosis. Explain what you are doing while doing it, then describe your findings and the possible diagnosis. And here it says describe, not just mention. Report your findings to the examiner, either as you proceed or at the end. So these are very objective instructions. What to do it? Do you need to tell the examiner anything? Etc. Now, examiner's instructions include issues should be explained during the orientation meeting, because examiners need one, maybe more than an orientation meeting, to tell them you will be sitting in this station. These are the instructions. This is the context stimulant. These are the instructions to the candidate. This is the marking form or scoring form. And you are expected to do this and not do this, etc. So these are explained during the orientation meeting, but are also given in writing to the examiner. What the examiner is expected to do and how they should do it, what is allowed and what is not recommended. Don't talk, don't trigger, don't do this, do this. You can start with this. Tell the candidate you don't need to examine for pain, etc. You tell the examiner exactly when to trigger. Do you want to trigger? Please start this or this. Do they have the chance to correct if the student goes wrong? Do they have to interact if the student tells them something? Do they reply? They ask questions at the end? All of that should be written as clear instructions to the examiner. And also they should be told how to use the scoring form. So it is written at the top of the form. Do this, do this, do this. There are instructions written at the top of the form. And maybe there are some rubrics added to the form. We will talk about that maybe later on. But anyhow, in the instructions, you will say, please use this and that. When you use the form, do this and that. You can also look at the rubric to do this and that. So all of these are called instructions to the examiner. Now, the patients, both real and simulated, need to be told how to behave during the task. Do they need to ask, as we say in Sudan, كلمة وغطايتها يعني, ولا do they need to explain in detail? Do they need to only answer questions? And when they answer questions, should they be brief or they go into detail? So all of these should be included in the instructions to patients. Now, what to say and what not to say and how. And that they should respond to questions precisely without additions. And of course, they need to be told they have to be cooperative with, they don't hide. We tell them what to say and what not to say, but we don't expect them to hide things and make the candidates suffer. So these are the instructions to the patient. Now we're done with the instructions for the three, the candidate, the examiner, and the patient. You need to prepare a marking sheet, a sheet that will be used by the examiner to give marks to the candidate. Now, these marking sheets, of course, used to be hard copies. Now people are moving into soft mark sheets, and they are usually given in a tablet. And if you, in your institution, you have exam soft, part of the exam soft is called exam score, and they actually provide sheets that can be redesigned to be used in the OSCE. So these marking sheets, how do they look like? Now, of course, the marking sheets contain statements of the expected components of the process, and the design is quite diverse. If you look at examples, you will find some people doing this, some people doing that, categorizing the statements or just listing the statements. There are different types. I will show you quite a number of examples to show you how diverse they are. Now, they are diverse as far as the content, the what inside. What do we expect? For example, if I say this patient came with pain, interview this patient to try and determine a provisional diagnosis. So when I say interview, I expect the patient to be asked about 1, 2. They should ask about medication history, presentation, details of the pain, etc. This is called the content, and this should be stated in the statement in this in the scoring form, because if they are mentioned, then the student will get a mark. If they are missed, then they lose a mark. So the content, you need to decide which content is essential. If the student doesn't include that content, then they lose marks. So you need to specify the content. But you also need to specify the technique. How did they actually ask the questions? Where they go, where did they build rapport with the examinee, with the item, with the patient, and so on. So the process is also important, and the importance of the process will depend on the level of the students. When we are training them as young doctors at the beginning of the academic journey, we emphasize this aspect. The technique of the process is very important, and until it becomes second nature, then we don't need to include it in each station in the future. Now, also the report, the details of the report. It's not only the process, the details of the report. How do they deal? How do they approach the test item or the patient? The report is very important. Also, we need, if in the instructions we said, explain what you are doing, then we will say, he palpated the abdomen and he said, he is trying to find this. He inspected, and then he said, or she said, the candidate said, he is now looking for scars for this, and that. So the running commentary should also be included if it is required. Because if it is required, it needs to be there, because some students will mention it, they get the mark, some will miss it and will not, they will lose the mark. So a running commentary should be included if it is required. Also, if you told them to mention the diagnosis, then you need to include it in the marking sheet. You will say, he said it's probably anterior myocardial infarction or whatever. So the interaction. He answered the question. When he was asked about this, he said this, and that. All of that should go into the scoring form. So these are the same. Now, to make it structured and objective, an objective assessment of the candidate's performance. This is the main purpose of the marking sheet, and this is exactly why it is called an objective structure. This is part of the structuring of the objective structure examination. Now, there are various types of marking sheets. One of them is just a standard checklist. He did this, and that, yes or no, done or not done. It's called the standard checklist. It's a checklist, check. And this is one example of the checklist. As you can see, there is only one column to the right of the statement. And you can also see that in this checklist, it is categorized. These blue sections, it's an introduction, and then the general inspection, then the hands, pulses, regular venous pressure, the face, closer inspection of the chest, palpation, etc. So this is a comprehensive cardiovascular examination. All what is expected from the candidate is there. As you look very carefully at the top section, which is called the introduction, they washed their hand, they introduced themselves, they confirmed the patient by looking at the name, blah blah blah. This is it is the process. It's the process. Now, in the general inspection, they inspected this. The auscultation, they auscultated the mitral, tricuspid, pulmonary, etc. So you make all the expected statement of all the expected actions, and there is just the right-hand column, and in that column, the candidate will just tick. The examiner will just tick when the candidate actually does the task. And by the way, such a long checklist need to be given to the examiner before they come, because they need to read through it so that they can remember that whether what the candidate has done is in the list or not, so that they will find it very quickly and they can actually score it. This is another example. It is just pen history taking, very similar. But as you can see, the content is the history of the presenting complaint. Site, ask where the pain is, onset, the Socrates. And also the communication at the end. He summarized, he thanked the patient, he disposed. This is process, this is the technique, this is approaching the patient. So there are sections about what they do, and there are sections about how they do it. Active listening, summarizing, signposting, etc. So this is another checklist, and this is a third checklist. Is about counseling, and the same. It contains content and it contains technique and approach. Now, that was a checklist. Done, not done, yes or no, and this is usually used for young students. I mean, students in second year in modules, order system modules, and all of that. You can actually examine them using the OSCE, but they use just the checklist and short checklist targeting the technique. But if you are examining senior students in fourth or fifth year, or graduating students, you use the rating scale, because the rating scale will give you the chance to make judgments beyond yes or no, the extent of performance. So this is called the rating scale, and in the rating scale, you will have levels. For example, this is done correctly, attempted, done incorrectly, not attempted. This is very simple. And then, as you can see on the right-hand side, they checked the knee sensation. With patient supine or sitting, the knee is extended. With patient prone, the knee is extended. With knee extension range is not assessed. So these are the three levels. The first one is done correctly. The second one, it's done but attempted but done incorrectly, and so on. There is explanation of when to give an A, when to give a B, when to give a C, and this is called the rubric. So this is the rubric on the right side, and this is what is expected, and this is the rating scale. By the way, as you can see, it's a simple rating scale. For example, this is another one, high hand disinfection, not attempted, attempted to incomplete, complete attempt. And this is a detailed rubric depending on suturing. And this is, by the way, from veterinary. It's very good as an example of a checklist with a rubric. Sorry, a rating scale with a rubric. Now, whether you have a checklist or a rating scale, you can add something else, what is known as global rating. Because the checklist and the rubric, you just tick, or here or there, tick. But to make an overall judgment on, they call it the global rating, you can add it to the checklist at the end of the checklist, and you can also add it at the end of a rating scale. So the checklist of the rating scale with global rating. And if you look at this example, the rating scale starts from a 0 to 2, and at the end, then there is 0, 1, 2, 3, and 4, and this is for the global score. How do you rate? You don't look at what you did there, but what is your impression about the performance, the overall performance of the candidate? Then you can say, well, to me, he's a 3. It's not a 4, but he's a 3. He's excellent. He's good. He's very good. And this is a more detailed, and the scale is not 3 levels, it's 7 levels. 7 levels. Below expectations, borderline, meets expectations, above expectations. He made me speechless. He's fascinating. This is the rating scale, but it's a detailed rating scale. And then at the end, what do you think? Is it incompetent, borderline, or competent? And then as you look at number 11, it says overall ability to perform the procedure, including technical and professional skills, and this is given a mark. So the global rating can be quantified and use it as a mark, part of the mark. And then the lower one, the incompetent, borderline, competent, or clear fail, clear pass, or borderline. this is used for standard setting. So these are two types of global rating used in the same rating scale form. And as you can see, this particular rating scale is used for graduates because we need to check exactly do they meet the expectations, or they beyond the expectations, or they below the expectations, and what about the global rating? How much shall I give them for this for their overall performance? And to me, are they a clear pass, a clear fail, or a borderline? And this, at the end, I can use it for what is known as borderline standard setting method. So this is a detailed rating scale with both types of global rating in the same rating scale. Now, this is the marking sheets. It's either a checklist, a rating scale, and the rating scale can be simple or elaborate. And then you can add a global rating, and the global rating can be quantified as a mark or used for standard setting. Now you need to list the requirements for the station. You start with the furniture. What do you need for such a station? Is it just a desk because the students will be sitting, going to interview the patient? The patient will be interviewed by the candidate, or what? Or is it going to be a bed? And then, what is the item? Is it going? The item can be a patient, real or simulated, a task trainer, a mannequin. You already listed that in the station's profile, but you need to list it again in the requirements, because this requirement list will be used to check the venue when you are preparing for the exam. So is it going to be a task trainer? Is it going to be a mannequin? And if the mannequin is the high fidelity one, what is it? And then any safety gadget, if you want to check whether they are aware of this patient safety issues and infection control issues and all of that. So you specify whether you need gloves, you need a hand sanitizer or what. And if there are any tools and equipment that needed for that station, a stethoscope, a sphygmomanometer, an ophthalmoscope, an otoscope, or a thermometer. So you need to write all of these in the list. Okay, then this stations khalas is now ready. You prepared all the elements, and then you are supposed to save them in the bank. Before you save them in a bank, you need to first validate. They are designed by somebody, excellent, no problem. You give it to a reviewer. Just technically, they look through it, and then you give it to another reviewer, which is a content expert. And the content expert will check as far as the content is concerned, as far as the technique associated with the task and all. So the reviewers will check and whether the task is quite objective, very clear. So they check for objectivity, they check the content itself for reliability. Now, they can also be calibrated in a mock run, because we would like to see the borderline student, will they be able to hear this merma or not? And is there a merma? Let us bring a registrar, let them check, or even a consultant to check whether the merma is audible. This is called calibration. And we also check how long does it take. You said you wanted 10 minutes. And then we brought a group of students, different levels, and we asked them to have a mock run of the station. And then we average. We discovered that even the slowest of the students could do it in 5 minutes. Why are you asking for 10 minutes? So it should be calibrated. It should be calibrated. Reviewed, then calibrated. Then a recommendation is you test the station in an exam without giving it a mark, and you check the performance of the students in that station. If it is okay, then you khalas back. So you calibrate it, and then you review it, you calibrate it, and then you test it before banking. So this is what you do, and then you code them, label them, and add them to the bank. The coding means what sort of classification. This is the code. And then you use a label short for this classification to be added to the bank. Okay? Now we prepare the stations and we put them in a bank. Now we want to use them for an exam. What do we do? Is it different from the statement we mentioned about the elements and how they are prepared? Yes. We have a profile, we have a context stimulant, we have instructions, we have marking forms and all of that. And all of that is in the bank. When we dig them, we take them out. These are the elements. And we have all of these in the bank, and we brought them out from the bank. How are they going to be different when we prepare them for the exam? We add the context, of course, we use the context stimulant and the instructions together in a page. And you saw examples. We will give the context stimulant followed immediately by the task or the candidate's instruction in the same page. And it is preferred that all of the stations are added to one candidate booklet. People look at this issue differently. Some institutions prepare a candidate's booklet, and when the candidate comes, they give them a booklet with all the stations. So this is preferred by many institutions. But others say, no, we don't need to waste paper. We will just print the paper and give it, put it on the wall or on the screen near the patient or near the station, and then the candidate will stand and read, and then they go one paper in the station for all the students. If it is now electronic, then there is no issue because there is no waste of paper. You can give all the exam in an iPad, and then they go through the stations, they read through station number 7, they do it. Then they go to a rest station and start preparing for the next station by reading through, preparing themselves. When they go in, they go straight into the task and so on. So it's probably in one candidate booklet, whether it is hard or soft. Okay, then also copies of this sheet can be posted at the entrance near the item and or at rest station. For example, if station number 7 has got an item, station number 9 is a rest station, station number 10 has got an item. They call it an active station. Now, there are rest stations, active stations, and static stations. Active and static stations, both of them can have copies of, for example, if we have station number 10 is an active station, number 9 is a rest station. The scenario for, or the context stimulant for station number 10 can be posted on station 9. In addition, it is also in station 10 because at the beginning of the exam, one student will be in station 10 to start. So they need to have a copy there. So anyhow, there are different approaches, and as I mentioned, it can be done, but it depends on what you opt for. Now, also the context stimulants, the instructions to the candidates and the instructions to the examiners are put in one page, together with the marking form, and these are given to the examiner. Instructions to the patients is also put in another page and is given to them, to the patients. So as you can see, we have a number of elements there. When we prepare the exams, we use them differently. We put them in 3 separate pages, one for the examiner, one for the candidate, and one for the patient. This is just an example. The background, which means the context stimulant, it's a longish history. Advil is no longer helping is lessened. There is no history of acute injury, etc. Additional history is not pertinent to the task. What is the task? Perform a complete knee examination. because we need focused knee examination based on the history. The time allowed is 15 minutes. So this is the page which is given to the candidate. This is another one, station number 1, time is 5 minutes, objective of the station. The objective of this station is to test your ability to take a focused history from a patient with difficulty in swallowing. Read the following scenario and follow the instructions and or answer the question. The station scenario or preamble. Ahmed is 65-year-old, etc. The instruction or the task. Interview Mr. Ahmed and make a focused history to explore possible causes of his problem. دي ورقة للcandidate فيها كل شيء. Okay, any questions? Station construction. This time I will give you a couple of minutes so that you can think of questions.
يا بروف كيف؟
Yes, أهلا وسهلا.
أنا دعاء، بس عندنا شوية أسئلة كده في ال Q&A في from Dr. Hamza. How he assesses the competencies in intern through an OSCE, and is any different between conducting an OSCE in undergraduate or at an internship or as a new term EPA?
Okay. I totally understand the question because I mentioned it, but at the beginning. I said when you are designing a station, you need to think of the level and the task itself. When I say the level, I mentioned if it is going to be part of an organ system module which is delivered early, we are more interested in the technique of examination, not the ability to actually detect symptoms, signs. So the difference is in the station for a junior candidate, we focus on their ability to actually perform the technique. They know how to examine the knee, but maybe they do not know how to hear the clicks in the knee. I will not bring a real patient with a click in their knee. I will not bring a swollen knee because I am just interested on how they actually deal, how do they carry out the examination. We call it the technique of the examination. Now, also, we will be more focused, I mentioned this also. I will be more focused on the approaching the patient, on the professionalism aspect. I will focus on them early because we want to inculcate the abilities in the student. So at the beginning, most of our checklist and scoring forms should contain a lot of that. Later on, we reduce it and minimize it because it becomes a second nature in the students. We definitely check it again and again. We check it when they are junior and we check it when they are interns. So it depends on the level. You determine the task and you determine the scoring form. Okay, now you mentioned EPAs. EPAs is very similar to these levels, but the EPAs, they have milestones. For each level, I'm going to deal the same what I just mentioned, but it is applying the milestones of the entrustable professional activities. When they are in the organ system module, I am going to deal with them at a lower level, and I'm going to use
تعالي يا ريم وتعالي اقعد هنا خليناها توضح.
ميوت يا ماهرين. Again, entrustable professional activities, they created milestones for these entrustable professional activities, and you actually use exactly what they prepared as milestones, and they actually prepared for the milestones, they prepared rubrics. So we expect them at this level. Their communication skills will be at this level. We expect them to perform at this level, and we are going to check them at this level. When they go to become more senior in the clinical rotations, then we expect them to be more, the mastery of the task will be at a higher level, and our expectations from them are at a higher level. So the milestones are used to actually check them at the various levels. If they are now interns or they are registrars or trainees, then we go to a higher level in the EPA. Okay, have I answered this, Hamza? Okay.
Okay,
Any other
Tani,
question?
we have another question from Dr. Nusayba. Some examiners do not stick to the instructions. How we can deal with them?
Do not stick up. They do not stick. They are not. They are incompliant. Huh? So how do we deal? There are two levels of dealing with such issues. The first level is called corrective action. Corrective action. Well, it happens. It happens all the time. We had an incident last exams. We had one strict examiner. He doesn't comply with the instructions. He goes beyond that and he's giving low marks to everybody. So you need to correct that. This is called the corrective action. You need to normalize the result using a correlation. You see how the candidates performed in other stations and you normalize their performance in this station based on their overall station. This is called corrective action. Now there are preventive measures, so this doesn't happen again. And this has got two levels. The first level, you speak to the examiner, you tell them and you show them the evidence. You didn't comply with this, you didn't do this, and the results of your candidates are not as good, and so on. So you warn them, you say, well, okay, no problem. Next time we expect you to comply with the instructions. And if not, then we are sorry, we will have to stop you as an examiner, we will bring somebody else. So this is how you deal with non-compliance. Okay. Other question?
Okay, bro. We have another question from Professor Fadwa. How we manage a station that need different times at one cycle?
This is actually, we are going to address this in the final part, but it's okay. I mentioned the calibration. And we need to have some compromises. The first compromise, if for example, most of the stations they require 4, but there are a number of stations that they require 6 minutes. So we try to strike a balance and make all of them 5. Students are going to waste about a minute in a couple of stations, 3 stations, and they have to rush through these longish stations. Or we say, well, this station you are asking for too much, and most of the stations are asking for 4 minutes, and you are asking for 6 minutes. Because of this, we need to correct the station so that it measures. It requires only 4 or 5 minutes. So you either change the station or you change the timing of all the other stations. This is one. For example, if we have all of the stations require 4 minutes, but there is another station that requires 8 minutes. So we double this station. We double the time for the station. I mean, the bell will ring, but we will have very clear instructions to the candidate. When the first bell rings in these stations, don't leave, continue with the task until you hear the second bell. And there are logistic arrangements for such an approach. There are logistic arrangements because when the bell rings, another student is supposed to come into this station. We will have another parallel station. Then one student will be still inside that station and another student will come, but he will go into another station. There are logistics. It's a complicated thing, but this is how they do it, doubling the time. Okay.
Sorry, Prof, but another question from
Yeah, sure.
Dr. Ahmed Omar. How to calibrate an OSCE station?
Calibrate has got two meanings. And first meaning, if the designer says this is a patient and this patient has got a bruit in their thyroid gland, we will bring some junior doctors and we will give them the stethoscope and we will ask them to auscultate the thyroid gland. If they are able to detect the bruit, then this is okay, this is good. Also, we ask some colleagues, and they also listen to the thyroid and say, yeah, it's a very clear bruit. The students will be able to hear it and all of that. So calibrating the science, checking the science that the designer said there are bruit. I'm bringing a calibrated standardized patient. I bring this patient every year, and this patient has got a bruit in their thyroid. This is one. The issue which we just answered the question about the timing. If somebody, I mentioned this earlier, if somebody said this station requires 10 minutes, we will run the station, a mock run. We will bring some students and we will ask them to actually go through the station and carry the task as relaxed as possible. And then we measure the time and we average the time. And if the time mentioned in the design is too long or too short, then this is the second type of calibration. Calibration isn't through checking it by somebody, teachers or clinicians and candidates or students, and also checking it through a mock run so that it's called time calibration. This is how we calibrate an OSCE station.
Okay, no more questions. Thank you.
Thank you. Let us escape from this one. خلاص نحن فهمنا انه لما نشغل. The last one is a short presentation about constructing an exam. Now we have a bank. We designed stations, we bank them, we prepared them for exams. They are now ready as stations prepared for the bank and prepared for the exam. Now we need to construct an exam. Let me go now. Of course, you don't see my screen, huh? Let me go there and say share. Okay, can you see my screen? Let me stop the first one and then share. أنا وقفتها الأولى والآن مشيت للثانية اللي هي exam construction share. خلاص افتكرت سلكنا في المنصة بتاعتهم دي. اوكي كده can you see؟
ايوه يا بروف واضحة.
Okay, now you have a bank of OSCE stations and you need to very quickly prepare an exam, an OSCE, an objective structure clinical examination. I'm going to give an introduction. Then we're going to very quickly touch on blueprinting and then preparing the exam and preparing for the exam. When you construct an OSCE, this is usually, it is supposed that we, with the course committee or the rotation committee or the clerkship committee, when they prepare the syllabus, they prepare exam blueprint. They have a course blueprint and then they have exams. And for each exam, they are supposed to prepare an exam blueprint. Then the subsidiary OSCE committee, because you need to have a committee to prepare the exam, will translate it into an exam. They will translate the blueprint into a real exam. by going through, by selecting the stations or freshly designed, or pull them from the bank. You select them from the bank, or you say, okay, in the blueprint they say there is هنا history taking station من الكارديوفاسكولار system فخلينا نعمل واحدة عن ال MI. أو they already specified and they are found in this bank and you just pull the station from the bank. So you either pull or you freshly design a stations. This is in general. Let us go back to blueprinting. Blueprinting is important because you need to ensure the balance in the instrument. Yani the instrument you are using, which is the OSCE in this case, is balanced. Balanced in what aspect? You are choosing the appropriate and balanced content, and this is called content validity. We look at the we prepare a blueprint that we ensure content validity. We had a rotation. In that rotation, we had 5 sections. They went to the internal medicine cardiology, they went to gastroenterology, they went to and so on. So we want to make sure that all of this content is actually sampled. So you need to ensure balance, and this is ensured through blueprint. You also need to ensure alignment in relation to content validity. What do we mean by that? It's not only looking at what they are supposed to do. We look at what they are supposed to do, which is the outcomes, and then the teaching. What sort of teaching did they cover this content? And then we make sure that it is in the exam, because it happens. For example, we can have this, and for this, we have something which is taught in the middle, as you can see, but it is not part of the objective, and it is not in the exam. So this is waste of time. We don't need to include it in the exam because it's not in the expected outcomes. Yes, it is taught, they saw patients about it and everything, but it is not part of this rotation, and they are not supposed to have studied it. In the blueprint, they are not included. But there are incidences when they prepare a blueprint or prepare the exam. There is something which is included in the outcomes. It is taught, it is learned, there were activities about it, but we cannot see it in the exam. So this is, we detect it. We either detect it in the blueprint, there is a problem with the blueprint, it's not balanced, it's not covering everything, or it is in the blueprint, we take the exam later on. If it's not a reflection of the blueprint, then we have this type of problem. Something which is in the part of the outcomes, and it is taught and everything, but it is not in the blueprint or the. A third incidence would be there is something which is the outcomes, it is not covered, neither as teaching or learning, and it's in the exam. It's in the blueprint and in the exam, and this is also a problem. And the worst one is there is something which is not in the outcomes and not in the teaching, and it is in the exam because the exam was produced from somewhere, from the internet, from a book. It's not aligned. So this issue of alignment is very important in relation to content validity. So it is not only the content as content, but also in relation to outcomes and teaching. Okay, this is the part which is compliant when we have outcomes, teaching, and assessment are constructively aligned. So this is an important issue when you prepare a blueprint or an exam. With regards to blueprinting, the blueprinting is to determine the distribution of test items. We are preparing an OSCE, we have 20 stations. How are we going to distribute them? Distribute them as far as components of the course and the skills in the course, because we are now addressing skills. Are we addressing communication skills? Are there procedural skills? cognitive skills, physical examination skills. So how are they balanced? Is it a balance? So the blueprinting will ensure this balance. The levels, the contents, and the domains. The levels, the content, and the domains. So the number of each content component, the themes, the topics, the activities, or objectives, this needs to be determined. يعني لما نقول content مثلا cardiovascular system or a cardiology rotation, what are the components? What are the themes? Are the themes divided into heart, then blood vessels? And is it heart, then arteries, then veins? What are the themes? Now, what are the topics? When we say the heart, what are the topics in the heart? Now, what are the activities? What sort of activities? Have they done clinical pathological conferences? Have they done tutorials, case-based discussions? Did they go clinical rounds? The activities of them, and of course, the outcomes of the audits. You need to specify these for why? Because when you do the blueprint, you need to specify which of these four you are going to use. Am I going to list the activities? And based on the activities, I'm going to determine the test items to cover those activities, or is it the topics, or is it the themes, or is it the objectives? Because people do it differently. Most of them now do it using objectives or outcomes, but at the end, you need to list all of them and make them ready when you prepare a blueprint. Now, you want to ensure content validity, balance, and appropriateness. And appropriately, you are doing the right thing, and you are checking you are doing the right balance. This is related to content validity. How is it done? Of course, it should be done by a content and process expert. And these ensure that a list of properly weighted content items, themes, topics, activities, or objectives for the test is ready. Weighted means, what do we mean by weighted content? For example, I have a rotation, it's a pediatrics rotation, and we have gastroenterology problems, you have respiratory problems, you have cardiovascular problems, you have renal problems. But what is the weight of each component? What is the weight of each component? They should be weighted because I don't want to give a large number of stations to a very small and unimportant content component. So I need to list properly weighted content items. And then a decision is made. Which type of content are we going to use? Is it themes, topics, activities, or objectives? It's a decision. And then you prepare a grid. The grid will list the content item on one axis. Doesn't matter whether it's in the column or in the rows. And then the type and number of questions on the other. Type of questions means, is it a physical examination thing? Is it a communication thing? Is it a history taking? Is it a procedure? Is it data interpretation? What type of station? And how many? And then they go through the content items and decide on the type and number of test items based on that. Now, based on the weight of each content item, and this weight will depend on how important it is. For example, you might have something of a small size. Small size, what do you mean by size? The content itself is not that much, but it's very important. If the students don't know it, it's a disaster. So based on the importance and size, both of them, you decide the weight. And then based on the weight, you decide the number of stations as a percentage. Now the final grid, after you prepare it, it should be reviewed to ensure that a test will be appropriate and balanced. Maybe you go and decide, well, I am going to use a procedure for this, I'm going to use communication for this. But at the end, you look and you discover that 1/3 of the exam is about procedures, while the course is not like that. The balance is skipped, so you need to correct the balance. So you have a look at the blueprint once it's finished to make sure that it is appropriate and balanced. This is just an example. In the left-hand side, you list the content items. For example, content item in A would be whatever, in B, in C, in D, and then you go through the different types of examinations. By the way, we have a key for this. The first column will say the number, the total number based on the weight and the distribution. For example, for this case, we have A, the content A, based on the weight, has got 9 stations. The 9 stations, the first one station is history taking, and 8 stations is about test find, over test find. You interpret the test find. So 8 and 1 makes 9. For example, there is a therapeutic procedure, 5 of them, and 2 is physical examination. So as you can see, it depends it depends on the content item, the weight of that content item, and the nature of that content item. You will specify what type of stations you are going to select and how many stations. Let us go to the next example, and it's clearer, and it has got explanation of what HT means. HT means history taking, and we are interested in history taking the technique, while we can also be interested in focused history taking. So for the first one, for infertility, we are just going to have a station on history taking the technique and identification of abnormal test finding, 1 station. So 2 stations there because it's only 10%, and the 2 stations are representative of the nature of the content. So here we have a blueprint based on the weight and based on the number of stations based on the weight, and the weight is based on the size and the importance. So we prepare this blueprint using these content components or items and their weight, and we determine the number of stations, and then we distributed the stations based on the. It's very clear that this course is for junior students because it's mostly about history taking the technique. History taking the technique, and also so very few pelvic pain and obstetric hemorrhage. They ask for focused history taking, and then other communication. Other communications mean breaking of bad news, taking an informed consent. These other types of communications, they use them for 4 components and so on. And the physical examination, because it's obstetrics, they just early pregnancy loss, and there is here is a physical examination. So this is a sample blueprint. And by the way, SE is sign elicitation. We expect them to elicit the sign. The sign is not visible to start with. They need to carry out a procedure to elicit the sign and so on. So these are examples of, this is an example of a test blueprint. This is another example, the competence categories instead of components. We want a number of history taking, so we put them, the components at the top of the columns, and the component categories, the competence categories on the left-hand side, and they used it similarly. And instead of putting station, they actually went straight ahead and selected the actual clinical condition: chest pain, shortness of breath, headache, jaundice, etc. This is another type of blueprint. Okay, we prepare the blueprint. How do we translate this blueprint into an exam? Preparing the exam. What is the procedure for the preparation of the exam? The blueprint is translated into what is called a stations list. So, for example, they said history taking cardiovascular system. Now, which condition? And then we will say, okay, this is maybe we bring heart failure. So here we made it into a stations list based on the clinical presentation in that stage. So we make a list of, it is not just numbers, not just one history taking, one procedure. What exactly is the procedure? And the history taking is about which condition. So we convert the blueprint into a stations list. Now, the station, we determine the list. So we said heart failure. We go in the bank and dig out a station which is heart failure and physical examination, and we pull it out. If there is no station with that, then we will say, okay, let us freshly prepare or design a station for heart failure, because we already have the patient, and the patient has got an edema and everything. Enlarged liver is ready. Let us freshly prepare a station. Okay, and then a test booklet, as we mentioned earlier, we compile all of the stations into one booklet. Now, this is the stations list. As you can see now, it's infertility, history taking, it's a stations list. We prepare this stations list because we need to look at the stations list and determine the sequence. So there are many stations which are history taking. Shall we say one history taking station followed by physical examination station, then two counseling stations, and so on. We convert this stations list into what we call a map, and this is the next step. Instead of having just as a list, we go straight to prepare the exam itself. When we prepare for the exam, the stations list is converted into an exam map. The first station is what? The second station is what? So we convert it into an exam map, and this is the template for the exam map. Instead of having them as just the stations list, we put them in the sequence we expect them to be in the examination. Okay, then we convert it into an exam map. We prepare the material. The booklet, the marking forms, the result forms, the signs, direction signs, and we prepare the timer to tell us that the 5 minutes have passed, and then the bell I'm going to use for the to announce that the students need to move from one station to the other. We prepare all these materials. Also, we prepare the examiners and the support faculty and the staff. We say, for this, we need this name as examiners. We need this as support staff. We need the secretary. We need teaching assistant to actually mark and help with this. And we prepare the examiners, the support staff, and the staff, support faculty and staff. Then we go ahead and prepare the venue with all the resources. The resources mentioned in the list. Remember that list for the stations? For each station, we say which type of furniture, which type of tools, which type of item. Is it a task trainer? Is it a mannequin? So I prepare all these in the venue, and then other logistic materials. OSCE logistics, I prepare a checklist. I give it to somebody. I tell them to go ahead and check. Tick. This is ready, this is ready, this is ready. This is called the OSCE checklist, logistic checklist. I prepare the backups. I have 20 patients, but I need another 10 patients as well. I have 20 examiners, but I need 5 backup examiners. Restrooms. I need a clinic. I need this, I need that. All these are logistic. Where are the staff and support faculty going to compile the marks and all of that? I prepare all of that before I conduct the exam. So these preparations are very important before you can conduct an effective OSCE. I wanted to mention this to complement the idea. The idea is how to conduct a quality OSCE. So we started by defining quality, then we specified, generally speaking, how do you do the cycle for the assessment cycle for the OSCE. Then we started by station construction, then exam construction, and delivery. Any final questions. Now it's an open Q&A, if you like, for a couple of minutes. You have 10 to 15 minutes if you like. And I will stop sharing.
Thank you, bro. We have this question بس جانا شوي متأخر from Dr. Asim Ali. We use domain-based marking instead of checklist, and we calibrate the examiners in the morning. Is one of the marking techniques better than the other?
ما فهمت السؤال.
Okay, we invite Dr. Asim. Okay, let's me check.
عاصم علي ده اللي هو عاصم غورش يعني؟
لا هو معنا في الستيج هيعمل لنا clarification.
كم
اتفضل.
السلام عليكم يا بروف، كيف حالك؟ أنا دكتور عاصم من University of Central Lancashire in the UK. We teach in phase 1. So in phase 1, in our OSCEs, we use a domain marking scheme for the examiners to mark the students. So we don't use a checklist. And the domain, it doesn't go but like numbers, as you've mentioned, 1, 2, 3, 4. We use unsatisfactory, borderline, satisfactory, or excellent. But then each one is a domain. For example, cardiovascular examination, it'll be inspection is a domain. And then you have for inspection, unsatisfactory, borderline, satisfactory, and excellent. And then also you have the palpation is a separate domain, and the auscultation is separate domain. And then at the end, we have the overall judgment, as you said, or the global judgment.
So when you said domain, when I shown the lists, whether it's a checklist or a rating scale, I call them sections.
Sections, okay.
Yeah. So you use instead of the section, I said introduction, then communication, then these are sections. But you use the sections as the domains of this in the station.
Yes.
This is what we
yes.
And you just ask the examiner to judge the whole domain, not
yes, exactly. Exactly. So I want your opinion on this. And is it better or the checklist is better? Because we always have discussions about it at work.
Yes. Maybe if you leave your communication, I will send you some articles.
Okay, excellent.
But in brief, I mentioned this, by the way, early better be as detailed as possible. I mentioned this. I said even in general, generic skills, the approach to the patient and all of that, you put them in detail because you would like the learners to appreciate these details, how to build the rapport, how to actually introduce yourself, how to actually do this, you go into details if you are teaching junior students.
Yes, junior,
Senior students, no problem, because they are senior students and you are going to bring senior examiners.
That's true.
So this is, we call it the expected and needed subjectivity, because this examiner is subjective. If you lump it, it is subjective, because they just globally evaluate their performance in palpation. But if they are young and you would like to actually remind them, they need to stand on the right side of the bed, and they need to warm their hands before they do this. And when they palpate, they need to press first like this, and then they do this. You put it in detail, and reports actually, the evidence is when you do this for the young, the junior learners, it is better because it helps them learn. And because you give them feedback after each, you need to give them detailed feedback. The examiner will not remember after the exam why he evaluated this as 5 and this as 3. Why? You will not remember. But if it is there in detail, then we'll say, okay, you have issues with this and that, and they will gradually improve when they reach senior years. They will be better, and we don't need to go into these details. When you say their performance in palpation was not as good, they know what was wrong with their performance. So change it. If you are using it for early, it's better to go into detail.
Okay, thank you so much. Yeah, excellent. This is exactly, we use it for early years, the phase 1 student, not the clerkship students. I'll leave my details as well. And while I'm here on the stage, I've got another question.
Yes.
It's regarding running an OSCE for a large number of students. For example, you have 300 students and you want to run it with making sure, no leakage of stations, the students are quarantined appropriately. You've mentioned earlier that you can split them into 3 groups. So I want just your opinion or from your experience on how to make sure that we run a very large OSCE for 8 stations, 12 stations for 300 students, but making sure quarantining them in an appropriate way, from your experience.
As you know, we Sudanese in general, not very keen on publishing. But we have a very rich experience in the University of Khartoum because we done this. Of course, the number of students is exactly what you said, 350 and all of that. And we did some studies. I mean, the main issue is, shall we conduct the OSCE in the same day, or we can spread it over 3 days? Because you are talking about leakage, okay? Also, if you are going to leave your your contact, I'm going to send you another type of study. It is about this leakage thing. Don't you think they already know? I mean, for a surgery exam, the list of stations, the possible stations, limited. It's going to be a lump in the thyroid, a lump, a breast lump, prostate examination, PR. Very limited. They already have a short list of the possible stations. This is point number 1. I mean, the issue of leakage is not a big deal because they already have a short list. If we do it today and tomorrow, or you do it the whole, all of them in one day, it doesn't really make a difference. This is 1. 2, if the students, you talked about imprisoning them. And I said, many institutions say, oh, take the mobiles and put them in that hole for half an hour or 2 hours maybe, and then they're waiting for this, and then you release this group and all of that. A study was done, and the performance there was no significant difference between imprisoning and not imprisoning. No significant difference. When they imprisoned and when they did not imprison, the performance did not change much. I mean, the second group did not benefit from knowing about what the stations were. In fact, one study said the performance of the second group was negatively affected when they knew what the first group had, because they were expecting certain things in the stations, and when they changed it a little bit, they insisted on what their colleagues told them, and so their performance was even worse. So you need to discuss and very carefully consider this need to incarcerate the group of students. Anyhow, if you insist in incarcerating them, we try the technique, which is we have 3 groups. Of course, we have different streams in the same day, but we have also 3 cycles. We will ask the first cycle to come at 8. The first group in the first cycle to come at 8. And they are going to continue for 3 hours. We don't need to imprison the second and the third groups. We will ask them to come 15 minutes before the end of the first group. Then we lock them for only 15 minutes. And they release the first group. We let the second group in. And we incarcerate the third group for the whole duration. Once the second group finishes, we let them go. And halas. So we incarcerate only one group, which is the last. And we register that. Next year, the group which was incarcerated in this exam, we bring them the first.
They go first, for example.
For example. So these are the logistics we applied, and they are very successful.
Yeah.
So there are two issues. Whether they know they are going to benefit or not, this is one.
Yeah.
If you say, well, we want to imprison them, you don't need to imprison all of them for the whole duration.
The actual practice we use is we show them the station titles 24 hours before the exam. For the junior students, but then there is lots of people against this, and it was like it's better to quarantine them, and it's a rare practice. We're trying to see other universities. Most of them, they don't show the station, but they still leak.
Let me ask you: if you are incompetent in abdominal examination, and you came in the morning of the exam, and then after the first batch finished, they told you there is abdominal examination on your side, and you are going to be examined in 3 hours. Are you going to change?
No.
Will you improve?
No, because it's a skill.
It's a skill. It's not how to do it. It's not a know-how. It's a show-how. Show me how.
Okay. Yeah.
You will not change in 2 hours. Maybe you will be better. As I told you, one of the studies, they actually affected their performance negatively.
Yeah. No, 100%. Thank you so much. Thank you so much, Prof.
Okay. Dua, any other questions?
Yes, thank you very much, Professor, for the insightful answers. I have a question from Dr. Hamza Muhammad. He's asking about highlighting the difference between OSCE and SPOTA, because he can see many colleagues confused between them.
It's not many colleagues, it's many institutions. OSCE is objective, structured, clinical examination. Okay? The issue is with the word clinical. Clinical is one, actually, when we say clinical examination, we want to test you whether you are ready for performance once you graduate. So we would like to see your ability to do things. So when you demonstrate your ability to do things, then we say now you are competent. We are assessing your clinical competence. What creates a confusion is, for example, if I bring you an ECG in an OSCE station, and I ask you to identify abnormalities, I ask you to interpret abnormalities, and I tell you the history and the findings of the physical examination, and I will ask you to tell me your plan, your management plan. Would we consider this an OSCE? Now, if it is part of an OSCE, it is part of an OSCE. The whole environment is clinical. There is physical examination, there is history taking, there is a communication other than history taking, there is, and then there are results, the ability to identify abnormal findings, then this is an OSCE. But if it is all spots, what is this? Well, this is a stethoscope. What do you use it for? And so I ask you about something, or I show you an image. What is this? You tell me that this is red eye. What do you think the diagnosis is? Now, this is not, you don't expect this when you graduate and you are sitting in a clinic. This is a spotter. This is a spotter exam. It is not even an OSCE. It is not even an OSCE. OSCE is objective structured practical exam. It is very similar to the OSCE. I am going to watch you perform and I'm going to assess your performance using a checklist. This is an objective structured practical examination. But if it is all images and instruments, I'm going to ask you to identify the instrument. And I'm going to ask you about the use of the instrument. This is a spotter examination. This is a spotter examination.
Thank you very much, Professor Sahel. I think the discussion actually increased the appetite for more resources regarding the OSCE. And here I have Dr. Nusayba. She asked you if you can name or provide them with a source to dig more on OSCE.
Yes, sure. We will find a way to share with them some resources after the conference.
All right, brilliant. One of the things that we prepared in this virtual platform, we put some sort of resources, a place to upload and share resources for particular sessions. Also, we'd like to invite you to use the virtual platform. We already prepared some sort of meeting tables and virtual rooms so that you can engage more discussion even after this particular session. Our esteemed speakers and instructors will be around every time, and then they have the time to answer and engage further in more discussion. We'll be happy also to collect all the materials from our esteemed speakers and share it with you within the virtual platform as well.
Okay, excellent, fantastic.
So far, no further question.
Thank you very much, organizers, and thank you also very, very much participants for attending this session. Thanks again. And thank you for the one I see in the platform, Dua, Ali Zayat, Hisham. Thank you very much. And I will see you in another activity. Okay.
Thank you very much.
Thank you, bro.
شكرا جزيلا، ممتعة كانت.
you.